Welcome everyone to the after lunch section on priority populations. My name's Dr. Luke Butcher. I'm a member of the Central Coast Local Health District Mental Health Exec. The first session today will be talking about cultural formulation, and then we'll pass over to Cage, who I'll just find the title of your presentation. Cage is Supporting Transgender People. So each presentation will go for about an hour, and then we'll have some opportunity for questions at the end. Please do feel free to throw questions out as the presentations go as well. So I'd like to introduce for our first section on cultural formulations, applying a cultural lens to Aboriginal consumers and addressing challenges of engagement. We have Dr. Vladimir Sashin. Dr. Sashin is a psychiatrist who has been working on the Central Coast since 2007, initially in the Wyong Mental Health Unit and later with the Aboriginal Mental Health Service. His main area of interest is general psychiatry, with a focus on delivering interventions to treat the most challenging mental health conditions, such as treatment-resistant schizophrenia and bipolar affective disorder. Dr. Sashin also works at Macquarie Hospital and has a special interest in mood disorders and neurostimulation. As I mentioned, my name's Dr. Luke Butcher. I've spent 15 years working in regional, rural and remote communities, leading a range of mental health, drug, alcohol and justice offender rehabilitation programs. I have a particular interest and passion in service design and delivery, and looking at how we can provide high quality models to people who access our services. Our third presenter, Lisa, is a proud Wiradjuri woman originating from Condobolin in Western New South Wales. Lisa has over 20 years experience in the health and community services sector within New South Wales. She has a Bachelor of Health Science degree, which she graduated from in Sydney University in 2004. So I will ask Lisa to come up and kick the presentation off, and we'll go from there.
Thanks, Luke. First of all, I just want to do an acknowledgement to country and acknowledge that we're on Darkinjung land. As Luke had indicated, I'm not from Darkinjung country. I'm originally from Condobolin, which is Western New South Wales. However, I've been living on the Central Coast for much over 20 years. I want to pay my respects to both elders past and present and any other Aboriginal people in the room. So thank you for joining us.
Cool. As I mentioned at the start, we're happy to have an interactive session here. As we talk through the slides, happy to get questions from the floor as we go to have a live conversation with everyone. So what we'll be talking about today, as I alluded to at the front, we'll be breaking the presentation up into three sections. I'll start off talking about the policy context of Aboriginal mental health. I'll talk about some key considerations as a health service, how we need to think about this idea of culturally safe practice and what that might mean for service design and delivery. I'll then hand over to Dr. Sashin, who will talk about the profile of Aboriginal people accessing health services in New South Wales and also locally on the Central Coast. And then we'll tie that together around some particular challenges for engaging Aboriginal consumers through our service. And how we've moved towards developing a cultural consultation liaison model to inform our practice and adjust our model of care moving forward. And at the end, having an interest in service design and evaluation, we'll touch on evaluation and what that might look like moving forward. So, what we know about the health and human services context is that Aboriginal people are significantly overrepresented in institutions of surveillance and control, such as acute mental health services, such as child protection services, such as criminal justice. And we know that involvement can be overlapping. We heard from our keynotes yesterday around this idea of overlapping involvement with services, this idea of intersectionality. So there's a lot of crossover between different types of disadvantage that are thought to contribute to Aboriginal overrepresentation in acute services and institutions of surveillance and control. There was a report conducted by the Australian federal government in the mid-2000s called Taking Time for Doing, which was looking at some causal factors that drive overrepresentation. And they basically, after conducting complex literature reviews, interviewing community members, etc., basically thought that overrepresentation was driven primarily by two factors. The first was chronic social and economic disadvantage that's experienced in communities, and the loss of cultural knowledge, norms, values, cultural identity and practices as a result of colonisation. Now, if we think about that first stop point around chronic social and economic disadvantage, that's kind of, I don't want to use the term bread and butter, but that's something that our services are quite adept at. That's something that we factor into service delivery models. It's a consideration in how we provide services in community, from acute community programs to subacute and rehabilitation focused programs. That's something that we're pretty good at. Something that we're not so good at, and it will really start to challenge our position as a health service worker and as a representative from government institutions, is this idea of loss of cultural knowledge, norms, values and cultural identity. And how do we start to integrate this second part of this perspective into our service delivery models? Yeah, how can we do that in a culturally safe and culturally responsive way? And I also appreciate that I'm a non-Aboriginal person at the moment talking about this as well. So my section will really be providing some reflections on a non-Aboriginal service delivery manager about how we might start to engage with these thoughts and the limitations in that space as well, yeah? So at the moment, there's an impetus for our service delivery models to work closely with Aboriginal people and communities to incorporate cultural safe models of care. And I'm going to come back to this idea of cultural safety shortly. Basically, the policy context is giving us a couple of key directions moving forward. The New South Wales Aboriginal Mental Health and Wellbeing Strategy, which was released late last year, talks about service delivery models incorporating three goals. The first goal around holistic person-centred family care and healing. The second goal around culturally safe trauma-informed quality care. There was a good conversation last night at dinner around the importance of trauma-informed care. So we'll be looking at how to incorporate that into a service delivery model moving forward. And connected care. The Gaia Dewey Declaration, the Proud Spirit Declaration, promotes the importance of mental health services to recognise Aboriginal concepts of social and emotional wellbeing in mental health, healing in practice, and to strengthen Aboriginal leadership and influence delivering high quality mental health programs. The key thing these three policies have in common is this idea of culturally safe practice and how can we incorporate cultural safety into our organisation. Cultural safety, in this fantastic quote by Pat Dudgeon and Helen Milroy and Ros Walker, it extends our perspective from cultural awareness and cultural competence to moving towards this idea of cultural safety. Cultural safety is a concept was originally developed by a Maori midwife by the name of Ramsden in 1999, who spoke about what underpins cultural safe practice is understanding the role of self, so understanding my role as a non-Aboriginal manager, managing Aboriginal health programs, the rights of others, including our patients and our communities, understanding and privileging the legitimacy of difference in perspectives, the legitimacy of difference in community, the heterogeneity within Aboriginal community, understanding the limitations as a non-Aboriginal person supporting Aboriginal mental health services particularly. And how we look at moving towards cultural safety is undergoing what we call a process of reflexivity. So an explicit interrogation of our positions of power. Again, I'm a non-Aboriginal man working within a government organisation, which comes with a range of institutional power associated with that, and understand that the way Aboriginal people have accessed services before hasn't necessarily had great experiences there. Again, and also my background is in psychology, and we know that psychology and social work particularly have been highly criticised by critical scholars and Aboriginal scholars as saying that the approach to assessment, diagnosis, treatment is bound in ethnocentric and Western models of health and wellbeing. Yeah, it's very biomedically orientated, very psychosocial orientated, very disorder focused, very deficit focused, very segments and compartmentalises people's experience of self. So if we're moving towards a culturally safe model of care, as a non-Aboriginal manager, we need to look at how can we lean into ideas of Aboriginal ways of being, knowing, and doing, yeah, and how can we embrace that, understand that, accept the risk that comes with that as well, operating a clinical service, yeah? Make sense? Oh, went backwards. So this is a model of social emotional wellbeing by Guy and Dudgeon et al., looking at understanding the experience of Aboriginal people who may present to an acute mental health service or a tertiary mental health service. We're not necessarily looking at the biopsychosocial model of health, yeah, which is kind of what we're trained to do as mental health clinicians, understand how biology, psychology and sociology all interface to create a picture of health. What this model of social and emotional wellbeing is advocating for and describing is we need to understand the socio-political and historical context of Aboriginal people. We need to understand the impacts of colonisation. We need to understand that hopefully our models of care won't continue to perpetuate colonial practice onto Aboriginal people. We also need to think about how do our models of care align to this idea of connectedness, yeah, as opposed to biopsychosocial dysfunction, which is kind of core business for mental health services. So how do we start to incorporate this alongside clinical teams has been a question that we've been wrestling with for quite some time, about 18 months. So this is kind of setting the scene for our thinking about our service delivery model. So as a non-Aboriginal manager, the challenges in this space for me has been how do we incorporate this idea of cultural safety into our clinical service delivery models? How do we ensure our models, our service delivery, our organisation is culturally safe for not only Aboriginal staff but Aboriginal people who are accessing our programs? Yeah, really, really important. And how do we start to lean in and engage with this idea of Aboriginal ways of knowing, being and doing? Yeah, really, really important if we're going to move towards cultural safety as opposed to cultural competency or cultural awareness. Importantly, that if we're operating in a state health service, how do we engage with this model of social and emotional wellbeing? If we're looking at a primarily biopsychosocial model of health, how do we start to incorporate this model into our thinking, and how can this inform what's happening in inpatient and community teams, yeah? And how do we integrate an understanding of this socio-cultural and political position that Aboriginal consumers occupy, and how do we implement that into treatment planning and understanding the historical trauma, the current traumas experienced by Aboriginal people into our service delivery? So that's a kind of philosophical perspective. I'll throw to Dr. Sashin, who will talk about the rats and stats of what we know about how people access services.
All right, okay, thank you very much, Luke. Hello, Vladimir Sashin. It's very nice to see you here, particularly the people with whom we used to work together. Thank you very much, Luke, for this great introduction about the basic principles. And now we'll try to show what we've been doing recently in order to develop our project to improve the mental health of our Aboriginal consumers. First of all, given that we've got not necessarily mental health professionals here, I want to give a big picture so that you could see the scope of the problem. And I picked up a couple of recent, probably the latest reports of the Department of Health published in 2017 and 19. So what we have in here, if we look at the rate of admission or hospitalization for Aboriginal patients or consumers, the picture actually doesn't look very good. If you take a age standardized hospitalization, age standardized means adjusted according to the age. We'll see that Aboriginal population have an 1.2 times higher than non-Aboriginal the rate of admission to hospitals, general hospitals. And what was actually worrying that over the last 5 years, the rate of admission rose at a faster rate than for non-Aboriginal population. For Aboriginal consumers, it was 58%. For non-Aboriginal, it was 16%. And that picture was the same across the all age groups. That also reflected in the disability statistics. If you look at that, that's the governmental figures. In our state, 48% of Aboriginal Australians age 15 and older reported disability or restrictive long-term condition. Again, it's 1.8 times higher than for non-Aboriginal population, for general population. And consequently, the Aboriginal Australians needs higher level of assistance, higher level of support, twice as non-Aboriginal. You could see the problem. It was also important that Aboriginal Australians see that their health status in general not as good as non-Aboriginal population. If you look quickly at this graph, and I can comment that 40% of Indigenous Australian self-assessed or rated their health as excellent, only 40%, and 26% as fairly and poor. Comparing with non-Aboriginal population, it's probably 0.6 times low in excellent health and 2.6 higher than in fair or poor. So that's the general statistic shows that yes, we're dealing with a significant higher rate of medical admissions for Aboriginal people, significantly higher level of disability, and significantly higher perception of assessment their health as worse comparing with general population. Okay. Now, what we've got in mental health, it's pretty much similar picture. In our state, the rate of Indigenous Australians who reported very high level of distress was 31%, comparing only with 10% for non-Indigenous population. There was quite significant increase of admission rate for Aboriginal consumers. And of course, I think most people are aware of the statistics of suicide. And I want to repeat again that the rate of intentional self-harm of Indigenous Australians 1.4 higher than the non-Indigenous, not Aboriginal. In the low graph, you could see clearly that the trend has been the same over the last few years. So looking at this picture, we started thinking and started developing our project with a view to improve the post-hospitalization or post-discharge follow-up of our patients. Why it's so important? We could look at the statistics again, and the paper that was published recently from Northern Territories showed that approximately 80% of Aboriginal consumers coming to emergency department report suicidal ideation. Certainly less percent presented with a self-harm or intent, but it's quite significant, 80%. So some of them are admitted to the hospital, some of them discharged from emergency department with community follow-up. Okay, so if we look what happens with patients who were admitted to psychiatric hospital, usually with mental illness and suicidal ideation, then they successfully treated and discharged. However, there was quite significant issue with post-discharge care. We looked at our numbers, and I have to say that the statistics in the Central Coast LHD similar to the statistics across the state. There's no difference. I I didn't quote that, but our numbers roughly in the middle, not the best, not the worst. We looked up and we did a bit of breakdown of the on the patients who were discharged from mental health unit and represented or readmitted again within 4 weeks. What was interesting that our consumers who were discharged from the hospital and readmitted again had a significantly low rate of 7-day follow-up. 7-day follow-up, it's a very important indicator because it shows the initial engagement with mental health service, acute care team, or other providers, maybe other mainstream services, maybe GP services. But that is a very, very important indicator, and it was low. If we look at the consumers who were admitted within 4 weeks, almost 90% had drug and alcohol problems. What was the most worrying that 33% presented with the suicidal ideations again within the period of 4 weeks. And that was very regretful that almost 30% were lost to follow-up started from day 7. So in other words, there was no engagement after the discharge, and then they had to be readmitted again within 4 weeks period. And majority of the patients suffered from psychotic disorder. In order to try to understand the gaps in providing our service, we looked at the other number, which again very, very useful. That's another survey, fairly recent, the last one before in the pre-COVID era. And the Department of Health ran this survey, getting feedback from Aboriginal consumers who were admitted to the hospitals. I have to say, not psychiatric, but we can extrapolate this data on our mental health consumers. And what they found, number one, the question to our Aboriginal consumers, if they received support from Aboriginal health worker that they wanted to have, 56% unfortunately said no, there was no support. If they needed to talk to doctor, did they get opportunity to do so? Again, 10% said no, we didn't have opportunity to talk to the doctor about this. Was it enough information given to your family, carer, or someone close to you? 22% said not enough. Did the hospital take your family and home situation into account when planning your discharge? 30% said no. Did you receive contradictory information from the staff? 30% said yes. And when you left the hospital, were you given enough information about how to manage your care at home? 11% said no. Again, I want to say it's not mental health patients, but I would probably assume to some degree, maybe to high extent or less extent, that's also true for our consumers. So we started thinking, we identify the problem, we identify some sort of potentially gap in our engagement, and we started thinking how to develop a model of care that could specifically address these gaps. And what we've come and put together a project when we start with the cultural formulation, which is the core tool for engagement of the consumers. And we'll show what we've done with that. And having developed cultural formulation, established the initial contact with Aboriginal consumer, we'll continue following up this person on day 7 by giving phone calls and having a follow-up appointment with Aboriginal mental health team around week 3 in order to improve the engagement of the consumer with the services that is going to follow them up. The services could be acute care team, mainstream services, our partners from Yeren Aboriginal services, or general practitioners who are actually involved in their services. So we thought that this model is worthwhile to develop, and we're very keen to share some of the ideas, what we started and what we're doing. And I want to hand over to Lisa, who was a driving force behind this developing and implementing cultural formulation. Okay.
Thank you, Dr. Sajan. First of all, I just want to acknowledge that I'm not normally very confident at speaking in front of an audience. For those who know me, and there's a few of you in the audience, know that I'm a very casual person. So I welcome you to seek clarification and ask questions if I'm rambling and talking at 100 miles an hour, which I feel like that I am now. So moving forward, when we reviewed sorry, I'm only short too. So when reviewing the model of care, we toyed around the idea of care coordination and what the dynamic makeup of what the team existed of. Ideally, the Aboriginal mental health team covers Gosford and Wyong, LGA, and inpatient and outpatient services. And what that means, we have a consultant psychiatrist 1 day a week, and a full-time psychiatry registrar, myself and 2 other Aboriginal health workers actually in the team to provide care, inpatient care to our consumers. And I guess when you think about that from a practical point of view, how do we meet the demand and how do we incorporate skilling other clinicians in the service around working more effectively with our Aboriginal consumers? So really that's how the concept of consultation liaison really came about. I guess in terms of at a more personal level, in my own personal experience of being an Aboriginal health worker in the LHD for over 20 years, it was always very noted to me in my early training, what is the role of an Aboriginal health worker? There was no clear scope of practice around what does an Aboriginal health worker actually practically do. Are we nursing staff? No, we're not. Are we social works? No, we're not. Are we a part of allied health? No, we're not. We're an Aboriginal health team that provides cultural input into a clinical perspective into the treatment of the way that the consumer is actually managed. Over the years, I've tightened those sort of scopes of practice with my Aboriginal health colleagues, and in our conversations with Aboriginal health and Nanyara, the Aboriginal Health Unit, the example that the manager there gives is if they weren't Aboriginal, what would the clinician do with that Aboriginal client? How would they engage them? But in terms of and taking into context the cultural and traumatic experiences around why they're currently presenting the way that they are. So with the team's support, we came up with a bit of a tool to structure and provide a bit of a formulation on why the Aboriginal consumer is presenting the way that they are, with understanding around and emphasising their cultural background and their traumatic experiences that may have led them to their current presentation. I guess the example that I often comes to mind when I hear myself talking about cultural formulations is that, I've worked in a mental health setting for quite a number of time. You often have an Aboriginal person presenting in a acute inpatient setting. They've come in a bucket paddy wagon on a Section 22. They're elevated, they're anxious, they're guarded, they're being detained against their will. And what that's like for an Aboriginal person, it can be quite intense. And part of the work that my team does is to support and engage an Aboriginal consumer to really articulate their current presentation. So often you see an Aboriginal consumer, again with that similar presentation, coming in on a Section 22, detained against their will, drug-induced psychosis, the intoxication, so many words, wears off and they sober up and they're pushed for a discharge. But soon as the Aboriginal health worker presents, often all that guarded presentation around trauma, dislocation, social and emotional well-being, distress, is really coming forth in why they're presenting the way that they are. So often, some of our consumers are looked at drug-induced psychosis or drug and alcohol presentations, but when we think about it from a cultural lens and a cultural perspective, we can see that they've been dislocated from their family, they've been dislocated from their mob, that they're homeless, they may have struggled with academic needs in their life, and struggling to access help at that level in the terms of accessing a traumatic, a tertiary service like an acute psychiatric inpatient unit can be re-triggering in terms of their current trauma and their current presentation. So hopefully with the work that we're doing around cultural formulation and providing an Aboriginal context in the inpatient setting alleviates some of those presentations. I've put together a bit of an example of, I'm going to flick through and come back, of a case presentation. It's not on there. It's not on there. That's okay. I'll just talk to it. Can I just grab that? Of how we implement a cultural formulation on our inpatient unit. One of the examples that we have is, we have an older Aboriginal woman who presents to an acute psychiatric unit. She's got a diagnosis of schizophrenia, schizoaffective disorder, with other comorbid sort of health issues like COPD, diabetes, a history of sexual assault. She's originally from, rural country New South Wales, known as Gomeroi country, Moree, and feeling quite disconnected from her family because of her past experiences. Had multiple admissions over time. And they haven't always been that therapeutic in her experience. So with the formulation, I've been able to articulate that to the treating team around how you can support that consumer through her recovery. She's also very well known in the Aboriginal community and accesses local Aboriginal services like Bungaree and Yeren and all those major players in our community. So there's also a fear of shame and stigma that sort of comes with her presentation. Her family, because they're so well known, have that same shame and stigma that comes in their current presentation. So part of the work that I do is that cross-cultural walk and walking with them in their story and providing that psychoeducation to not only the consumer but their extended family and their community. So many times, families struggle with their family members being admitted into an acute psychiatric unit. Oh, yeah, sorry, I missed the big one. She's got multiple family members who have accessed our service, our mental health service, and she's got a son who is very well known to our service and is managed on clozapine. And she's detained against her will. It was thought that clozapine would be the most advisable sort of course of treatment in terms of her care. And I guess in terms of the limitations and why the family was so hesitant to have her accessing mental health services is that when she was commenced on clozapine, she had an allergic reaction or a reaction to the drug. And I guess the family thought trial medication, playing guinea pig on my family, which some of those stories that you guys have probably heard through, removal and those transgenerational traumas that have so often happened for our people. So I guess part of my role was really sitting in the treatment and in with the treating team, including the family, around supporting her through her process. She was discharged on a community treatment order, which was somewhat restrictive in terms, but it supports her engagement. Part of my role is to support the discharge plan around engaging, and the cultural formulation sort of implies all levels of engagement, not just with the consumer, but with all parts of her community and her local Aboriginal medical service that she accesses. I'm nervous. Thanks, Rach. yeah, I guess all this stuff that we know, it's all about stronger engagement and including Aboriginal health workers in all levels of treatment of their care. I guess when we reviewed the model of care, we were getting referrals really bizarrely, and now that I think about it, haphazardly, we'd be getting referrals from nursing staff, from the doctor staff, the medical officers, sometimes ward clerks. Sometimes I would just see an Aboriginal person on an inpatient unit and refer them to myself. And I guess that's not really what the role or how things should probably be implemented in terms of incorporating cultural interpretation in a person's healthcare. We've now added Aboriginality on the pre-admission checklist for Aboriginal consumers. Do they identify as being Aboriginal? Would they like a referral to the Aboriginal mental health team? So that it's providing some consistency in terms of accessing Aboriginal health involvement. From there, they're allocated to the one treating team to provide some consistency in terms of accessing the psychiatry team around care.
So we're going to do the rest by interpretive dance?
Just a question while
Yeah.
I like that there's that conversation at the beginning about, would you like to meet with the Aboriginal mental health team? Is that something that's also reintroduced at a later stage of an admission as well?
Absolutely. And I guess it's done at the beginning of their admission, and not all the time that Aboriginal consumers will want an Aboriginal health worker involved in their care. But I guess given that they're allocated to the one treating team under the one consultant in Wyong particularly, it's offered throughout their care. I attend the MDTs, and there have been a number of consumers that have then been re-referred later in their recovery. And I guess when you think about an Aboriginal person's experience in an acute psychiatric unit, you know that they're sometimes fearful of being judged, being stereotyped, being detained against their will. Some of the work that I encourage our team, the Aboriginal mental health team and the medical officers, is to have that more casual style of working with our consumers, having that yarn, so to speak, so that it helps that engagement process, allowing people to tell their story, allowing them to reconnect. I mean, some of the examples that you give, and I'll draw on my other Aboriginal colleagues in the room to acknowledge or support or disagree, but when an Aboriginal person often meets another Aboriginal person, we ask where you're from, who you are, where's your mob from. And I guess when I'm talking with other clinicians, you don't really need to go into a whole lot of detail and disclose that you're Lisa from Berkeley Vale and you've got 3 kids. It's just a way of alleviating some of those myths and engagement processes with Aboriginal families, is that I'm Anthony, I'm part of the mental health service and I live in Terrigal and I'm really interested to hear about where your people are from, and that supports that engagement process and allows Aboriginal people to feel a part of it, included in their care. I'm lost.
Yeah,
But,
I'd like to agree with Elise just to talk to that, and I feel the same with LGBTQI community as well. I think, I know as Aboriginal people and having worked with Elise, there's very few of us, and when you're in these big systems, and I'm now in private systems, it gets, it's a lot
yeah.
for us to look after the mob. One of the best initiatives, I don't know if you're still doing it, is when you started to identify staff in the inpatient units and they wore Aboriginal t-shirts. I think little things like that, and about cultural safety and being trauma informed. So even if they're an ally of LGBTQI or Aboriginal health, and they're just safe within how they approach those people, is enough, because we can't run around to everyone. And I think just having that t-shirt or that identity in a unit, the patient will then gravitate to that staff member because they're reflecting that they're safe in that context.
It doesn't put all the premises on,
Yeah.
obviously, Lisa and the
Yeah.
other Aboriginal liaison officers. If you've got medical staff and nurses who are trained
Allies.
for safe, interactions with
that concept of wearing the identified shirt really came from when Georgie was on the team, and we talked about, you know, so often our presentations are higher on the weekend. They're coming in, you know, in the back of the paddy wagon. You've got nursing staff greeting them in the Ambo Bay. Their experience around being detained may not have been a positive experience in the past. Just seeing someone wearing something Aboriginal can say, hey, I'm safe. Hey, I'm mob. Yeah, hey, I'm here to take my time with you and not rush through the tick box and get stuff done in a system way that we know that our inpatient units have to do that stuff. But I guess one of the things that I reinforce to nursing staff, if we're wearing the Aboriginal shirt, we do need to take our time and and see ourselves as a bit of a champion in engaging Aboriginal consumers. It's not just a free ride, just to
Reinforce that because
Something doesn't come with it.
the leadership that the two of you did was to actually say you can't just wear a shirt. There are a lot of expectations that come with this, and that was really good.
Well, it's something we want to try to do in the private sector too, you know, I just think to acknowledge a safe place for priority populations and diverse people is really, really important. However you do that, acknowledge with a t-shirt, a safe place to become.
I was just going to say that opens up the conversation generally with people that where do you get your t-shirt from? One of them, and that relaxes them straight away as to, you know, well, why are you here?
and
Talk about that.
it's a tool and it's a focus to destigmatise what may be else going on in their current presentation. I mean, so often I gave the example of drug-induced psychosis. I had a consumer, you know, admitted again on a Thursday afternoon. By Monday, she was ready for discharge. She had, you know, detoxed and for a better word, had sobered up, so to speak. And the treating team couldn't actually see any sort of psychotic phenomenon happening for her. But as soon as she could see me walk towards me, she called me aunt. I don't even know why she did that, but it was quite overwhelming that she did that. And then she's rattling off all of this stuff that she's from rural Queensland. She'd been looking for her family, and particularly her dad, but was mixing up famous Aboriginal people as part of her identity and was still quite floridly psychotic, but was being quite guarded around that presentation because she knew that the team were going to detain her against her will. But with the support of the Aboriginal health team, we were able to talk about what that trauma meant for her and how to support her in her recovery and a discharge plan in a way forward. I guess in terms of the model of the care, and I'm getting a little bit anxious because I need to move it forward, is that from that cultural engagement process around, you know, providing a cultural formulation into their treatment plan, post-discharge, the team are now providing a 7-day follow-up from the Aboriginal health staff, and then with the view to review the consumer within a 3-week period to support engagement with those external services like their GP, like any other support services that they may need in their community. So I guess this is a new concept, a new way of rolling out our model of care that Rach started it. We're rolling with it now, but we're open to feedback and some suggestions on a way on how we're integrating into service.
Sure. While we wait for the slides, I'll just talk briefly about evaluation. So, as Lisa and Dr. Sashin mentioned, our end hope is obviously culturally safe practice for our Aboriginal consumers. We are hoping that rates of 7-day follow-up and 28-day readmissions will decrease and be an indicator for that. Dr. Choi, who's in the room, is leading a project around this for his scholarly project. It's one of those words I can say here but not here, around working that model up. Of course, we're without the slides. I will talk briefly about, again, the cultural formulation document. We're looking at current and historical engagement with services. So thinking about trauma, thinking about that complex intergenerational trauma, thinking about that complex social pictures that Aboriginal patients often present with, and how will that inform our work moving forward with Aboriginal patients? How will we inform treating teams to do that work differently and engage in a more meaningful manner, as Lisa mentioned? Part of Lisa's process is understanding the cultural context of the patient. I've just lost my slides there too, so...
Puts you off, doesn't it?
It does now. They're really small and I've got really bad eyes, so that's okay. I'll keep going. So understanding the cultural context of that person, where's their community from? Often, Lisa, you've been consulting with a couple of patients at the moment that have had quite a fractured cultural connection, and helping patients explore that and explore their family connections.
I mean, so often we know that a lot of our local Aboriginal community are from other areas, like myself. We come from other areas, so our connection to this country is somewhat fractured. But that's part of their current presentation. How do they connect? How do they connect with this local Aboriginal community? What's that presentation looking like for them?
Cool. We're back on the air. The cultural formulation process again looks at identifying historical and current trauma that impact how clients may engage with services. So Lisa, there was an example of consulting with a young person that was in Brolga, and she was 16, 17, and her dad was quite a well-built Aboriginal man he was from the stolen generation, or had...
He had members from the stolen generation. He's originally, it just so happened he was from the same community I originate from. He's a really dark Aboriginal man, no hair, missing teeth, and quite boisterous in protecting his daughter. And I mean, his daughter was floridly psychotic, we were attempting to manage her in our PEC unit, but it turned out we couldn't quite manage that, and she needed to be transferred to Hornsby. So the family required quite a lot of support from the Aboriginal mental health team. I mean, at different points, she was taken to tribunal for an extension of her order, and at times, because he was trying to protect his daughter and being misinterpreted around what that looked like, at one time, I think there was probably 12 security staff on site to just participate in that presentation.
So your consultation to the Sydney team was about supporting them to understand Dad's perspective, yeah, and where Dad was quite frightened for his...
Yeah, and he felt like his words were, I feel like my daughter's been taken and I can't take care of her. And I mean, regardless of whether you're black, white or red, he's a dad and he's got a 16-year-old daughter. You don't want to